thrombocytopenia, although you'll see as the data evolves, I'll talk a little bit towards the end of the talk, that this has implications for treatment of secondary thrombocytopenias as well, and indeed has been looked at in a variety of malignancies and transplant settings, but those are still relatively early and non-licensed indications. So I'm going to talk a little bit about the history of and treatment of autoimmune thrombocytopenia, and then the main body of the talk I'm going to concentrate on the use of the new agents, the thrombopoietins, the recombinant hormones that stimulate platelet production. These are my conflicts of interest, a variety of companies that are all involved with platelet research and autoimmune disease. Immune thrombocytopenia has a very long history, but I have up here just the brief milestones over the last 100 years, and you'll see that in next year, in 2016, we'll reach the centenary of the first connectome for someone with autoimmune thrombocytopenia. And it was only 50 years later that standard therapy that those of you who treat this disease will recognize, which is the use of steroids. And those treatments have really been the mainstay of treatment of this disorder for at least the last 50, 60 years, apart from the advent of intravenous immunoglobulin in the early 1980s. And it's really only over the last decade that we've seen some real advances in treatment with the use of the anti-CD20 antibody rituximab and the thrombopoietin receptor agonists, which stimulate bone marrow function. ITP, for those who aren't aware of it, I put one or two simple slides in, basic slides for those who are mainly oncologists and won't understand the background here. For adults, 40% of patients are picked up incidentally, and we talk about patients who, when they're first diagnosed as newly diagnosed, historically have been called acute ITP. But we call them newly diagnosed because many of them will have had the problem for some considerable time before presentation. After 3 months, up to 12 months, we call them persistent, because at that stage many will achieve a spontaneous response. And it's only after 12 months that we talk about chronic immune thrombocytopenia. It's very important in making the diagnosis to look for secondary causes. There isn't a simple test that will allow you to say this patient has primary immune disease. And I put up here the list of diseases that are associated with it, and the first two, particularly infection, HIV, HCV in particular, are increasingly prominent. Liver disease, the background of liver disease is also associated with thrombocytopenia, and drug, both prescription and non-prescription, alcohol abuse are also extremely important. And so we always look for causes of secondary. Now, this was a slide put out about 5 years ago from the States, but this represents the proportion of primary and secondary in both the States and Northern Europe. In some areas in the Far East, it could be as much as 60% for secondary because of the incidence, particularly of hepatitis C, as we'll come on to. I shall talk a little bit at the end about the treatment of hepatitis C and these agents. But what are we talking about? When we look at immune thrombocytopenia, we tend to think of the difficult patients that you've seen who don't have platelets that respond, and so we were very keen to look at the natural history of the disease. And over the period of a year, from a number of centres in 5 countries, we just looked at newly presenting patients and what happened to them. And you'll see here from the third bullet point that only 60% required treatment, 40% required no treatment. And of those that required treatment, a significant proportion only needed 1 or 2, and a significant proportion came to hospital no more than 4 times in that first year. So we're talking about a very small number of these patients who actually had severe disease. Only 12% presented with bleeding, i.e. that's no more than 60 to 80 of those patients looked at over that year. So only a small proportion of these, maybe 5%, are those that fall into the severe disease category. And the mainstays of treatment for the newly presenting patient are corticosteroids plus or minus intravenous immunoglobulin or intravenous anti-D immunoglobulin. And that's non-contentious and straightforward. 80% of patients will respond initially, although this is only sustained in less than a third of that. It's what happens when what we do next for the patients who don't respond that become the problems. And of those who we do treat, only around 25 to 30% will be refractory, and only about a quarter of those will be truly refractory and very difficult to treat. So in terms of the second line treatments, there's not a lot to go on. There was a discussion of evidence-based treatment in the previous cases on antifungal treatment. These were two sets of guidelines, the International Consensus Report and a report put out by the American Society of Hematology 4 years ago. And you'll see in the International Consensus Report that choices are in alphabetical order. And that's because there is no evidence base to choose one above the other. It depends on personal experience, it depends on the health economics in the country where you're treating them, whether it's government-funded treatment, whether it's privately funded treatment, and to what degree the government funds the treatment. The only treatments there that have a significant evidence base are thrombopoietins, because they're the only treatments with large-scale randomized double-blind controlled trials to look at how the treatment works and what its place is. Now, the mainstay of treatment has always been chemotherapy, immune-suppressive chemotherapy, really up until around 2005. And this is a publication produced by one of the presidents of the American Society of Hematology, whose research team went through the literature to find cases where more than 10 patients were reported who had less than 10,000 platelets of presentation, i.e. patients actively needed treatment. And of the 656 patients that they identified, only 14% had a complete remission. Nearly 50% never responded. So those in the middle had some sort of partial response. So this is actually quite a poor return for treatment that has significant morbidity and potential mortality. And when we look at the cause of death in patients with refractory venous thrombocytopenia, these are three largish studies, two large studies and one personal study of a large number of patients looked after in one institution. We see that although the number of deaths are small, 50% of the deaths are related to infection, are related to the treatment. And they're invariably patients who are refractory to other treatments, may have had their spleens removed, and have failed treatment with failed splenectomy and required further immunosuppressive treatment. So within this group, we're actually causing significant morbidity and some mortality with the treatment that we're giving. So the question is, who should we treat? And there's always been a tendency to treat on the basis of the platelet count. Now, when you look at a platelet count of less than 10,000 or less than 20,000 in a patient with immune thrombocytopenia, they will bleed less than the patient with acute leukemia or aplastic anemia with bone marrow failure at the same level. And that's because the bone marrow is able to produce platelets. These platelets are functionally active. Therefore, you don't have to treat on the basis of the platelet count alone. Many patients with low platelet counts in ITP will not bleed. And therefore, you go on the basis of whether they're bleeding or not to decide on the treatment. You go on the basis of whether they're active or not. So a young person who does contact sport is going to need a platelet count that stops him bleeding. Whereas a hospital consultant who sits behind a computer is not going to need that because he's not stressing himself and he's not going to likely to bleed. People with manual jobs are going to need a platelet count of about 50 to stop bleeding. So you take all those sort of things into account in terms of deciding whether to institute treatment that may of itself have negative effects for the patient. And the sort of counts we're looking at for treatments are in minor dental surgery, 10 to 20,000 is fine. Minor surgery, more than 50. Major surgery, more than 80. So there's a lot of redundancy within the platelet count. A count of 80 or above will actually give normal hemostasis. You will not have problems with that. You don't have to aim to a platelet count that approaches the normal range to have normal hemostasis. For patients who have failed normal therapy, the standard practice, as I said right at the beginning, for the last 100 years has been to look at splenectomy for the next arm of treatment. And indeed, following the surgery, probably 80% will respond, but 20% of those will relapse. So that although 60% have responded, 40% will not. So that's 40% who require further therapy, who may actually suffer and will suffer the side effects of that further treatment. So we've looked at whether we can predict whether splenectomy will work. And this just says very much the same thing as I said in the previous slide. So we've actually looked to see whether we can predict whether splenectomy will work. And in autoimmune disease, one of the ways of doing that is to label the platelets with a radioactive label. We use Indian labeling here because it's a very tight label on platelets. It's a very good label at low platelet counts. And you can not only image where the platelets are being destroyed, you can actually then follow their half-life in the blood, so you know they're being destroyed early, and you can actually see where they're being destroyed. And you can see in this slide here, we're comparing the liver and the spleen with the heart background. In this particular instance, the spleen is almost completely destroying the platelets. So you can be certain there that if you take the spleen out, there's a good chance that that patient will respond to treatment, to that surgery. But when we look at the 250 patients that we've scanned and we reported a while back, you will see that those with purely hepatic destruction, 20%, those with mixed hepatic destruction, 23%. That's about 40%, which is the number that will ultimately fail surgery. So by doing this procedure, I can predict and tell a patient categorically that they will not respond to splenectomy. I can't, on the other hand, tell those with a pure splenic or a mixed splenic pattern that they will absolutely respond. But I can say to them, rather than a 60% chance of response, if you're a young person with a splenic clearance, you have a 90% plus chance of long-term response, which changed the odds considerably in deciding surgery. We did initially look at the outcome of splenectomy. We're analysing 91 currently. We're looking at those with long-term follow-up. You will see from here that those with splenic or predominantly splenic had a much better response than those with mixed hepatic. And fairly early on, we stopped operating on those with hepatic clearance because we felt it was unethical to do so. And so we now use this, if we're going to splenectomize a patient, to guide whether we proceed to surgery and recommend this to the patient or not. And it's much easier to say to a patient, you will not respond to surgery, we're going to proceed and look for other alternate therapies. And this is the impact it's had on the splenectomy rate in the UK. Pre the 2010 guidelines, it was running at about 13%. For the last 5 years, it's been running about 2%. The French have seen exactly the same pattern. Their splenectomy rate now runs at about 6% of patients presenting with ITP. And if we look at the time to surgery, this is over the last 30, 40 years, you can see whereas in the 70s, there was a tendency within a few months that once the patient had failed initial therapy to get in and take the spleen out. By 2010, we're talking at least a 3-year gap between diagnosis and surgery. So the patients actually have to earn their surgery. It's not something that's done as a knee-jerk reaction because that's what the books tell you to do. But of course, there's been a great interest in looking at some of the newer therapies, and really over the last decade, there have been a lot of new agents that allow us to consider some form of autoimmune intervention. And I mentioned rituximab earlier. You'll be aware of that, and I'll go into rituximab in a little bit more detail. There are a number of other quite interesting therapies as well. The SYK inhibitors, the spleen tyrosine kinase inhibitors, which block macrophage function. The drug there is called fostamatinib. It's being studied in a multinational phase 2 study at the moment to look at its impact on the treatment of ITP. It will put the count up in at least 50% of patients. It causes significant diarrhea in about 1 in 10 patients, and we're looking in the larger study to see how well tolerated it is. There are a number of other very interesting antibody therapies. Anti-CD40 ligand, which blocks the binding of the effector cells. Alemtuzumab, some of you will be aware of, which used to be known as Campath, is a pan-lymphocyte antibody and the co-stimulatory blockade of CTLA-4, which again blocks co-stimulation of the antigen-presenting cells with the effector cells. Unfortunately, although some of those agents have been effective in part, none of them has had the impact that we want. And that reflects the fact that the immune system has enormous redundancy. You block one path and another path takes over. So we're still looking there, but many feel that that's the ultimate way of treating autoimmune disease, of actually blocking and altering the immune pathway. The other main mechanism, the one that I'll talk quite a bit more about, are the thrombocytomimetics, of which the two Riblis and Eltrombopag are the ones that are licensed. Eltrombopag, the Novartis product, is the one that's licensed currently in Egypt, and I shall talk quite a bit more about some of the results of the early studies there. Just briefly to talk about rituximab. Rituximab has, as you will know, has been enormously successful in treating the B-cell malignancies, in particular low-grade B-cell malignancies, and has been used widely in autoimmune disease, and was used about 10 years ago in autoimmune thrombocytopenia. And there was a platelet response of at least greater than 50 times 10 to the 9th per litre in nearly 2/3 of patients. And in about 46%, a complete remission was achieved. And this is a meta-analysis that was reported at ASH. The response is between 5 and 6 weeks to occur and lasts for about 10 months. And that on the surface really looked quite interesting. We felt that this may be shifting the balance of the autoimmune process. But if you look at it globally over a longer period, and you look at 100 patients who present with ITP who are given rituximab, the initial response occurs in just about 60%. At 1 year, just over 30% have responded. By 2 years, that's dropped to 25, and by 5 years, it's about 20%. Now, if you don't give people rituximab, 20% at 5 years will have responded. So you're not actually altering the natural history of the disease, you're just altering the pathway by which it gets there. So you may give them 1 year's, 2 years grace from treatment, but they will ultimately require treatment to the same degree that other patients will who don't receive it. So although it's an interesting product, it's not the ultimate answer which initially we thought it was. That data has been confirmed by a very recent study published in Lancet by a multinational European group led by colleague Benina in Norway. The overall response rate was similar, the complete response rate was similar, but when you look at the treatment failures, although it slightly favours rituximab, there's no statistical significance. So the conclusion of that paper was that although there may be some improvement with rituximab, this was small, and it was just one treatment option in this group. There has, however, been some quite interesting findings. This was a paper published by Vassell in Hematologica, Vassell based in New York, looking at dexamethasone in combination with rituximab in this group. He found an overall response rate really very similar at 4 or 5 years out, complete response rate. But what he did was sub-analyze, and he found that patients who were treated at less than 2 years post-presentation, females, and those who went into complete response rather than partial response, had much better responses than those than the group as a whole. So beginning to pick out a subgroup that you can suggest ought to receive this treatment. And that was essentially confirmed by a report this year from the Italian group of Zaja, who again found that women have a much higher probability of overall response, that there's a higher tendency to achieve CR in younger patients, and this was particularly seen in those early on in their stages of disease. So what we're seeing here, although his overall long-term response rate was no better than the slides I've shown you, we're beginning to say here, well, actually, those who relapsed or refractory first-line treatment, you may be able to pick out those who are going to do well with this treatment. And so that's quite an important finding. You're not subjecting patients to treatment whereby they may actually have disbenefit. But the big problem with rituximab is the problem of infection. It's been reported that the instance of progressive multifocal leukoencephalopathy occurs. And I'd say this is much more common in patients with malignancy who receive other immune suppression, particularly intravenous cyclophosphamide. But it does occur in ITP, and this puts patients off understandably. But from my point of view, the bigger worries are the risk of hepatitis B reactivation and the risk of severe ordinary infections. Because these patients, at least 5% will develop hypergammaglobulinemia within the first year, and patients who are treated recurrently will have up to a 10% hypergammaglobulinemia rate. This doesn't recover, and this makes them severely prone to bacterial infection. And this, I think, is a major issue. I'd now like to move on to the thrombopoietin. Thrombopoietin has been suggested for pushing 50 years now. Ever since erythropoietin became available, it was assumed that there had to be a hormone equivalent to erythropoietin that stimulated platelet production. This was first described in the mid-90s when 4 groups published simultaneously in Nature of having sequenced and or isolated thrombopoietin. And this was established as a major megakaryocyte growth factor. This was summarized by Donald Metcalf, the Australian, who's probably the grandfather of growth factors and did much work on GCSF in its early days. Now, why should we give it to someone whose disease is associated with immune destruction? Well, one of the issues is that the autoantibody in ITP not only destroys platelets, but it damages megakaryocytes as well. And this slide here shows 2 particular studies from different groups. The top one shows an in vitro culture looking at megakaryocyte production in conjunction with ITP plasma. This is done by Bob McMillan in the Scripps Clinic in California. And you can see that at least 50 to 60% of patients with ITP have restricted megakaryocyte development, and a small percentage have severely restricted megakaryocyte development. These autoantibodies are preventing megakaryocyte production. And you can see from the bottom picture, these are EM pictures of the megakaryocyte. The one on your left is a normal megakaryocyte, the one in the middle and on the right are apoptotic megas. You can see the apoptotic vacuoles in these megakaryocytes that have been damaged by the autoantibody that's directed against the glycoprotein on the megakaryocyte surface. Also, when you look at platelet kinetics, when you look at the platelet production, the underlying theme in ITP is as the platelet count falls, production goes up. But if you look at platelet production in ITP, you will see that it actually doesn't do what it's supposed to do. As the platelet count falls, it gets below 50. We would expect to see platelet turnover moving to the right. In fact, it doesn't. It stays over either to the left or in the middle. And so these patients are not able to respond to the falling platelet count in a way that you would anticipate them doing. And the reason for that is that when you look at serum thrombopoietin levels in patients with ITP, it's lower than it should be. On the left, you'll see healthy donors with a normal platelet count. Thrombopoietin in healthy donors is virtually undetectable. In the patient with a low platelet count who's got an amegakaryocytic or aplastic bone marrow, the thrombopoietin levels are high. In the patient with ITP, platelets are low, as are the thrombopoietin levels. And that's because thrombopoietin is produced in a constitutive fashion from the liver. It's produced in a steady state production throughout, so it isn't stimulated by the platelet count fall. And so this steady state production of thrombopoietin is taken up and removed by the cleared platelets, and it's taken up by the megakaryocyte mass in the bone marrow. Therefore, there isn't sufficient to stimulate further platelet production. And so it was felt that if we could artificially stimulate the thrombopoietin level, this would provoke platelet production. And this was certainly shown in the first generation of thrombopoietins that were developed in the late 90s. That program ceased in the late 90s because the recombinant product had significant sequence homology to native thrombopoietin and provoked antibody production that destroyed the volunteer donor's own thrombopoietin they developed. thrombocytopenia. So the studies then didn't proceed until the second generation of thrombogrowth factors came through. These were the two main ones, the non-peptide mimetics, so trombopag, which is a small molecule, and the peptide mimetics, the Amgen product romiflozin, which is a protein molecule. The difference between those two is, of course, the protein molecule would be destroyed by gut enzymes and has to be given subcutaneously. The small molecule can be given as a tablet and is given on a daily basis. As I said, it's a small molecule that stimulates megakaryocyte proliferation, differentiation, and platelet release. It doesn't stimulate platelets, so it doesn't activate platelets. And as I said, it's orally bioavailable. And because these products have no sequence homology to native thrombopoietin, they provoke no antibody production, or certainly no antibody production that cross-reacts with native thrombopoietin. It acts on the platelet membrane part of the thrombopoietin receptor. Native thrombopoietin acts on the distal part, so it acts slightly differently. So it has an additive effect to native thrombopoietin. It stimulates the JAK-STAT pathway and the MAP kinase pathway, and through signal transduction increase produces platelets. There are a number of studies that went through to look at this. You'll be aware of these sort of studies. There were the original phase 1 studies to look at proof of principle, and then those that looked at dose finding, and then the phase 2-3 studies looking at safety and clinical effects. I'm going to go through some of these in brief detail. The original studies looked at dose-finding studies. The original 773A study looked at a dose of 30, 50, and 75 milligrams against placebo. And you'll see at 50 and 75, we're seeing response rates there of 70%. Now, if you cast your mind back to the responses of cytotoxic drugs, complete responses there were seen in no more than 15%. Certainly less than 20% of patients responded to those, as opposed to 70. So this was really quite a dramatic finding, quite a dramatic observation in this patient group. It certainly proved proof of principle that an ITP could stimulate platelet production, but did so in a major number of patients. So the second lot of studies chose 50 milligrams as the dose of choice in the 773B studies, and this has become the dose for starting patients off. Is 50 universally accepted in patients from the Far East who lack the enzyme to metabolize trombopag, and the starting dose for them is 25. And what we saw in this group, this is the response at day 43, this was a 6-week treatment, that whether the patients were on treatment or not, whether they had their spleens in situ or not, whether the platelet count was less than 15 or higher, they responded across the board compared with placebo. So, unlike rituximab, you're seeing a similar sort of response irrespective of the patient's stage, age, or sex, or position. And that's really quite encouraging. It means you don't have to start looking at subdividing or looking at categories. You just give it to the patient, and as we now know, 9 patients out of 10 will respond in some way to the treatment. The RAISE study, which was a 6-month study, was looking at it whether we would maintain over a longer period, comparing treatment with against placebo, and you can see that the upper 2 arms, which are the splenectomy and the non-splenectomy arm, were significantly superior, with little crossover of the error bars to show that there was significant response. What you also see, though, is when treatment finishes at 6 months, the count falls. But you'll also see from the error bars that some of those remain relatively high, and that's quite interesting. I'll come back to that later. So when we look at the key efficacy data in this study, you'll see that at least 80% have a count greater than 50 at least once. 20% will get counts over 400, which we don't like because of the potential thrombotic risk. And 25% of these will have a continuous elevation, of their count above 50 throughout the entire period of the study. And in association with that, you could also reduce the concomitant medication, which of course reduces side effects and the problems from that. One of the first thoughts of treatment, this would be used in two ways. One to cover procedures, interventional procedures, and the other to cover the periods when patients were having bleeding. And so we were keen to see whether you could give the patient treatment and then stop and then start again. And these patients were received Eltrombopag for 6 weeks, then had a 4-week washout period, then received another 6 weeks with a 4-hour washout period. And you can see that of these cohorts who received cycle 1, then 2, then 3, the responses are superimposable. So this is a drug where the effect doesn't wear off. You can continue to give it, and you will still see a similar level of response. So we went on from that to look at the Extend study. This is taking all the patients in the early studies to look at how we could treat them over a long period. On this aim, there were 300 patients in that, starting at 50, adjusting the dose to get the count over 100, then removing concomitant medications, adjusting the dose to keep the count over 50, and then maintaining them for as long as possible. And when we look at these, when we look at the response rates here, I won't go into the detail, but again, depending on baseline count, use of IT medication at their presentation, whether they were splenectomized or not, whether they'd been in the previous study and responded or not, the responses were in the region of 80% across the board. So again, this was proof of principle of a very effective treatment in this very difficult group. And if we look at those who maintain counts of greater than 50, in the absence of rescue medication for more than 50% of the responses, you can see that again, although the response in the splenectomized is slightly worse than the non-splenectomized, the responses are universally good across the board, infinitely superior to the response to the alternate therapies. The study has now been went on for over 5 years, a little cut off, and you can see here up until the blue box, 4 years, the responses were maintained. After 4 years, it becomes a bit more erratic because the numbers of patients are really very small, and when you've only got 1 or 2 patients, the change in count of 1 patient can impact on those results. But what it shows is that responses, if you need to give it long term, continue to be seen. Importantly, we were also interested to see that bleeding manifestations stopped, and in particular severe bleeding are reduced significantly over the period of the study. And one of the reasons for looking back, you would assume that if the platelet count went up, the patients would stop bleeding. There was a worry that these drugs could activate platelets, although the count could go up, they wouldn't actually work. This shows categorically that actually they do work, and you only see bleeding in those where you get swings and troughs and plateaus. Where the count falls, you may see bleeding, but actually the bleeding is much less, with very little at year 4 or 5. Importantly, the concomitant medications, 35% were able to reduce or discontinue completely their baseline medication, and 75%, or 35% stopped it completely, another 35% were able to reduce in general down to one baseline med, with the impact that had on the side effects of these drugs. There are a number of side effects. For those of you who use the cytokines, in particular the neutrophil growth factors, GCSF, GM-CSF, will know that they're often associated with non-specific myalgia, headaches, upper GI, upper respiratory tract problems. And these are seen with the thrombopoietins as well. Only a small number have to stop treatment, but they're there all the same. Around 30% of patients had what we classed as serious adverse events within this study. When you look at these, cataracts are actually no more common in the study than they were in the placebo arm. Thromboses were actually no more common, and pulmonellas were also no common, I'm going to come back to this, in the treatment arm than the placebo arm. The only specific treatment problem we saw related to the Eltrombopag was an increase in liver enzymes, and I'll come back to that in a later slide. We also are quite interested to see, and a lot of studies now associate quality of life, and you'll probably see that in your oncology studies, that these patients generally had a significant improvement in quality of life using some of the quality of life questionnaires over the period of the study. And if we look at this was published in the Lancet 4 years ago now. This was the first main report of the RAISE study to show that you'll be familiar that above the arm it shows an improvement, below the arm a deterioration of function. Using the recognised quality of life questionnaire SF36, short form 36, you can see the L-Tromopag, the deep blue bars, significantly outperformed placebo throughout the study. So not only were we making the patients clinically better by bringing the platelet count up and stopping the bleeding, we actually made them feel better as well from the point of view of side effects of the treatment and side effects of the disease. In terms of side effects, we were particularly worried about the problems of thrombocytosis and thrombosis here on the basis that if the count went up, they may clot. And we've certainly deliberately aimed not to put the count too high. We're aiming for counts with a target of between 50 and 150. Certainly if they're over 50, we're quite happy. We don't like to see them go over 150. We haven't seen the issues of platelet activation that I mentioned. There is the issue of autoantibody formation or antibody formation. We have seen, certainly in remiplastin, some antibodies developing to the drug, but these don't seem to negate the effect and certainly don't impact on native thrombopoietin because there's no sequence homology. Rebound thrombocytopenia is a potential problem. If you stop the drug quickly, in about 10% the count will plummet and they may bleed. So we actually now tail the drug off as we finish it. There are issues of bone marrow thrombosis, which I'll come back to, and the risks of stimulating tumor leukemia growth. We haven't seen that currently. There was a study in MTS that was terminated early 18 months ago because of the suggestion this was causing leukemic transformation in those in the remiplastin arm. In fact, subsequently it was seen that there was no difference in leukemic transformation between the leukemia arm between the thrombopoietin arm and the placebo arm. And it's generally felt that the trial was suspended prematurely for inappropriate reasons. And then the compatibility analysis, which I'll come back to now. About 10 to 12% of patients will develop increased liver enzymes while on the L-Tromopag. These resolve if you stop the drug, but in fact we saw from some of the earlier studies they resolve even if you continue with the drug. And the reason for that is, of course, that the enzymes are being measured centrally, and the investigators often didn't know of the impact on the enzymes on their patients. So what we did see was even in those, there was no actual signs of liver impairment. Although we knew about it, the patients were withdrawn from the study because we said it doesn't seem to be an ultimate problem, and it is something that occurs early on in the disease. It certainly doesn't occur if you treat. So over the 2 or 3 year period of the study, we didn't see a worsening of liver problems. In terms of thromboembolic events, 6% of patients had these. 25 thromboembolic events in 19 patients. These were EBT, CNS problems, MI, pulmonary embolus. But there were no more thrombotic events in the placebo arm than there were in the treated patients. Over the 3 years of the study, from 10, 11, and 12 presented ASH, there was no increase in thromboembolic events. And only 3 of the patients actually had these at the maximum that their platelets achieved. And this slide just confirms that. This was published in Blood in 2013. That the majority of patients hit their peak platelet count after treatment started. The platelet count fell as the dose was titrated, and only 3 of those did the thrombotic event occur at presentation. And one of the things that we've seen is, and this was a study we published a few years ago now, we looked at 1,000 patients with ITP compared with 4,000 age and sex-matched controls to find that the actual instance of venous and arterial thrombosis was greater in patients with thrombocytopenia. So paradoxically, although you thought the low platelet count would protect them from thrombosis, it in fact was more common. And it's more common, I haven't put the slide in, it's more common in patients with severe disease than those with mild thrombocytopenia. So the lower the platelet count, the worse it is. And we know that patients with thrombocytopenia may have antiphospholipid antibodies, but there's also a belief that the autoantibody damages the endothelium and causes vasculitis, which provokes the clotting cascade, and this is the reason for it. So you have to bear in mind that patients with ITP have a prothrombotic state, and that any treatment you give them, IVIG, or if you take the spleen out, or you give rituximab, or you give them thrombopoietin, if you push the count up too high, you may provoke thrombosis. And this is particularly the case in patients with pre-existing risk factors. In terms of the issues of reticular formation, this occurred again early on with ropenostin, when very high doses were being given in non-responders. Patients developed a leukoplastec picture and were found to have a increased fibrosis in the marrow. So studies were done to look at patients on longer-term treatment, and over the period 3 to 4 years of the study, we saw no increase in thrombosis over that period. And indeed, only 4 patients developed reticulin, of whom 3 also had some collagen as well. Of these 4 patients, 1 was ultimately lost to follow-up. 1 stopped eltrombopag and the fibrosis disappeared. 1 stopped the eltrombopag and refused further bone marrow, and the peripheral blood didn't change. And 1 insisted on continuing the eltrombopag because he felt so well about it. His grade 3 reticulin has not changed throughout. What we've also found is that over a quarter of patients with ITP actually have bone marrow fibrosis at presentation. And this is felt to be because of the production of transforming growth factor beta by the megakaryocytes, which provoke some fibrosis within the marrow. So this is a problem of ITP, not a problem of thrombopoietins per se, and at the sort of doses we use is not an issue. So a number of points I'd just like to talk about now. Whether is platelet fluctuation a problem? Can we switch agents? What about long-term use? And fluctuation can be a problem. It's more of a problem with rituximab, where the dose is given on a once-weekly basis. The count goes up, comes down, goes up, comes down. Whereas the eltrombopag as a tablet on a daily basis gives a much smoother pattern over the period. And on this slide here, we just took our first 6 patients and we charted out the weekly counts over these. You can see the count slowly comes up, and apart from the patient in yellow, there's little fluctuation. Even that patient, it's only a count of 20. It's not a significant fluctuation. So we don't believe it to be a major issue here. There's the issue of how long will we use it for. It was initially thought we would use it for short periods. Then it was thought, well, once you've got a patient on it, they're on it forever. But what we try and do now is at 6 months, particularly if there's a good response, we will tail the drug off and see what happens. If it drops and there's no bleeding, then we'll watch and wait. If it drops and there is bleeding, then we may restart. But what we found is that about 30% of these patients actually maintain a remission. And by maintaining a remission, we mean 6 months off all treatment, maintaining their platelet count. And this just illustrates that this is a patient actually under imiplastin, which highlights the rapid peaks and troughs that you see with the weekly injections. But with the counts being persistently above 100, the imiplastin was tailed off and the count stayed up. Our longest response has now been 4 years plus off all treatment. And certainly the 30% has been confirmed in a number of studies now. So we can be fairly certain that a pretty reasonable proportion of these patients will respond and remain off treatment. And one of the reasons that we believe that, if you look at the bone marrow of these patients, they have increased T-regulatory function, increased T-reg numbers and function. And we think that by some mechanism which we don't know, thrombopoietin is actually influencing the immune microenvironment within the bone marrow. In terms of switching, a number of patients you have to switch because either the treatment doesn't work, or the count fluctuates to such a degree you can't control it, or they have side effects. And you'll see from this slide here that response rates are between 50 and 80%. If patients have side effects, then virtually all will respond to the follow to the other agent. If they fail, the responses are less good, but they will still likely respond because they're different mechanisms of action. So we certainly can alternate between the two agents if we have to. So in summary for ITP, and I've got a few slides afterwards to talk about hepatitis C, we found that using these newer treatments, we get superior effects to the traditional second-line treatments that we've had. We now try and avoid splenectomy if at all possible, and 30% of these have a long-term remission. And studies are now underway to look at using these agents much earlier in the course of the disease to see if we can maintain the responses. I'd now like to talk a little bit about HCV. These drugs have been used in a whole variety of other conditions. I'm not going to talk about them all now. I mentioned a little bit about MDS. The results in aplastic anemia are really fascinating, with about 30% having trilineage responses. And there's a meeting to review that in Europe in 3 or 4 weeks' time, look at all the data. But that's a particularly interesting response, although a small proportion do produce a clone with monosomy 7. But I'm going to talk a little bit about HCV-related thrombocytopenia, because it is a growing problem. And you'll be aware of the prevalence of HCV, and in terms, as I was talking at the beginning about secondary thrombocytopenia, it becomes more prevalent in areas where HCV is common. Although only a proportion of patients with HCV will develop thrombocytopenia, this accumulation of studies here shows about 20% of those infected develop thrombocytopenia. And this is some studies from the UK over the decade following 94, when it began to be realised what a problem it was. Now, whether that's an increased incidence of ITP or whether we were looking for it is difficult to know, but we're not seeing a big surge in thrombocytopenia just because of the HCV, but there is an association with it. The causes are multiple, but in terms of what we've been looking at, the main cause is decreased thrombopoietin production due to loss of function in liver tissue. But of course, if you've got portal hypertension, the platelets get taken up by the spleen, the virus itself may induce marrow suppression. So there are a number of issues there that are underway. And the more severe the liver disease, the lower the thrombopoietin level. So looking at the fibrosis score here, and looking at the median thrombopoietin levels, you'll see they progressively fall the more fibrosis there is in the marrow, and this reflects liver damage. And the more severe the liver disease, again, this looks at a retrospective characterization undergoing liver biopsy, cirrhotic patients as opposed to non-cirrhotic patients, and the prevalence of thrombocytopenia is 2/3 in the cirrhotic group and is much less in the non-cirrhotic group. Now that reflects a platelet count relatively high, that's a platelet count of less than 150. And the prevalence of thrombocytopenia depends on how you analyse it. So looking at 250-odd cirrhotic patients, 3/4 had some level of thrombocytopenia, but then only 13% did that limit liver biopsy or interferon usage, and only 1% required platelet transfusion. But of course, the issue is, what's the problem? And of course, patients with liver disease bleed at much higher levels than normal patients with a low platelet count because of the occurrence of current deficiency of coagulation factors. So they bleed because of a mixture of platelet and coagulation deficiencies. So the tendency to be to want to treat the low platelet count, because if you push it up, then you're at least removing one of those arms of the bleeding risk. And there are a number of choices here. Standard steroids, try and avoid that because of the progression of liver disease. Intravenous immunoglobulin works quite well, but it's very transient. Antiviral treatment is obviously the treatment of choice, but has issues, which I'll come back to. So that was one of the reasons why there was an interest in looking at the thrombopoietin receptor agonists. And what you see here is if you look at treatment with interferon alpha, pegylated interferon at 2 different doses. If you look at the middle row, you can see that thrombocytopenia increases as the dose goes up. and increases significantly and requires, you'll see from the bottom row, dose modification of the interferon because of the low platelet count. And so that led to a study looking at eltrombopag at different doses compared with placebo in patients treated with pegylated interferon alpha. And you can see here, and I'm not, because of time, not going to go into this in detail, but you can see compared with placebo, you actually see a dose-response curve across those three doses, with at 75 and 50, the results being very similar, less so at 30, no change at all with placebo. And if you look at the percentage of patients who can complete their 12 weeks of antiviral therapy, nearly 65% on the higher dose